Yes, thank you very much for the opportunity to speak today. And I did look at the list of speakers, and I didn't necessarily think I felt like the youngest, but I did feel like perhaps the least qualified. But thank you for the opportunity to tell you about a project that I've been working on now for probably, well, the last 4 or 5 years, and it's becoming an increasingly large priority in my research portfolio at Monash University. I joined Monash, or rejoined Monash after getting my PhD there about 6 years ago, with a focus on looking at developing drug delivery systems for the lungs in particular. And as we were doing that, we came up with a number of examples that we thought would be worth looking at a little bit further. And one of those examples was taking a hormone, oxytocin, which is used routinely in healthcare around the world. It's used to prevent and to treat postpartum hemorrhage. And that was where we started looking at this project, because there are a number of limitations associated with access to oxytocin in developing countries. And we thought that targeting delivery to the lungs would be one way to overcome that. And the idea of delivering drugs to the lungs is not new and it's not novel. And in the pharmaceutical world that I was sitting in, it wasn't that exciting. It was kind of cool, and we thought we could get some good papers out of it and a great way of training some PhD students. But it wasn't until I attended a conference that was hosted in part by the Bill and Melinda Gates Foundation, where they had put out a call for innovative technologies for delivering medicines and solutions for maternal and neonatal healthcare. And so I thought, oh, I'll go and I'll talk about this idea of inhaled oxytocin. And of course, people in the pharmaceutical world said, no, it's a bit boring. It's not that new. But actually, when I went to the conference to talk about it, it was kind of like, you can do that? And it just was an idea that hadn't really sort of crossed people's minds. And so I think what it highlights, which again is a message that's been coming through today, is that communication and bringing unlike minds and unlike experiences together is such an important way of identifying all of the key facets of how do we translate a medicine. So many of you will be familiar with the Millennium Development Goals that were first described in 2000 through the United Nations, where 189 countries agreed, or they promised, that they would find solutions to enable or to reduce poverty, reduce hunger, and improve the situations for the world's poorest people in the developing countries. One of those Millennium Development Goals, MDG 5, is focused on improving maternal mortality. And that ambition is to reduce maternal mortality by 75% by 2015, and also to obtain universal access to contraceptives. Now, MDG 5 is one of the goals that we are making least progress on. Progress has been made and it's promising, but still today, every minute, a mother will die from pregnancy and childbirth associated complications. Most of those women will die due to severe postpartum hemorrhage within 1 to 2 hours after giving birth. And the tragedy of that statistic is it is almost completely preventable. The drug exists, it's safe, it's effective, it's oxytocin. We use it in Australia many, many times every day. But in these developing countries, the biggest barrier, my biggest barrier might be going on to the next slide, is obtaining access to these uterotonic agents such as oxytocin. And so the policies are within those countries, the WHO recommendations, we follow those. Every woman will receive access to oxytocin after childbirth, but it is very much easier said than done, like changing slides. Okay, so just to describe some of the limitations with obtaining access to oxytocin, it requires cold chain storage, it requires refrigeration, or else the drug degrades and it loses its efficacy. It must be administered via a needle and syringe as an intramuscular or intravenous infusion by a trained healthcare provider. Yet most of the women in developing countries give birth at home and often alone. The quality of the products is a problem. There are a lot of counterfeit products on the market. And if it's not stored correctly, then the quality has deteriorated. And when those drugs are available, they're often used for purposes other than what they were intended, which was prevention of postpartum hemorrhage. So our research hypothesis was that we could develop an inhaled form of oxytocin. We could engineer particles, dry powder particles containing oxytocin that would not require cold chain storage and that could be inhaled by the patient, where it would be absorbed from the lung and reach the systemic circulation to exert the effect on the smooth muscles of the uterus and therefore reduce, prevent and treat postpartum hemorrhage. We wanted something that could be easy to administer, was needle-free because there are a lot of complications associated with administration. There is another drug that's recently been approved for this purpose, oral misoprostol, which can also be used in home birth settings, but it's not as, well, there's literature suggesting it's not as effective as oxytocin, it's not as stable as we'd like it to be, and it's also not available in some countries because it can be used for termination of pregnancy, and in many instances that'll prevent it ever being available to women, even for postpartum hemorrhage treatment. And so we think our inhaled oxytocin concept would overcome a lot of difficulties. But we're very much aware that women in developing countries where we're targeting this from, they're not familiar with inhaled medication. And so how are they going to accept this idea of inhaler? Is it going to be intuitive, and how do they use it? Are there preferences for whether this medication is orally inhaled into the lungs or inhaled into the nasal cavity, because it could be absorbed? There's no real biopharmaceutical reason why it couldn't be one route of administration over the other. And so I think that's why Helena's asked me to talk to you today, to talk about what are the processes that we've been following in order to try and really understand the end user and let that guide our development of a product. We know that we can develop a stable formulation. We know that it can be absorbed from the lungs, but if we don't have a product that a woman wants to use and is able to use, it will have no impact. And so we must understand the end user for us to do that. So the first stage of our project, and I'll briefly take you through some of this, is our preclinical evaluation. We've done the stability studies and we can show that we get good long-term stability at 50 degrees Celsius, which is well above ICH conditions. We've also got some preclinical pharmacokinetic evaluation. We've done this study in what we think is a physiologically relevant animal model, which is sheep. We can see here that the blue profile is after we've given an intramuscular dose of oxytocin to sheep, and we can see the plasma concentration profile versus time. And then the red dots indicate the plasma concentrations after we intratracheally administer a dose of our dry powder into the sheep. So it's not a full representation of the clinical situation, but it's enough for proof of concept, and it's enough for us to be confident that if the drug gets into the lung, it can and it will be absorbed and can therefore go on and have an effect. So we also had a pharmacodynamic model where we used sheep, postpartum sheep, within the 24-hour period immediately after lambing. We had connected electrodes, EMG electrodes, to the uterus of the sheep so that we could monitor smooth muscle contractility. The profile here on the left is the basal activity of smooth muscle in the postpartum sheep. So these sheep are not experiencing postpartum hemorrhage. They do not have an atonic uterus, which is often the cause of PPH in women. So it's not a full therapeutic model, but we have these basal baseline contractility in the smooth muscle. And on the profile on the right, we can see that within a minute or so after administering oxytocin into the lungs of our postpartum sheep, we see a very rapid and significant increase in smooth muscle contractility, which again was further confidence for us that we should take this project to the next step and look at being able to scale up and move towards the clinic. So what we've just been working through recently, and I just came back from a week in India, I think 2 weeks ago now, where we set out with the objectives to engage with the local stakeholders, the end users, the policymakers, the clinicians, and try and understand what were their thoughts and views on the idea of an inhaled oxytocin product. How is oxytocin currently used in practice? We know what the guidelines are, but how often and how closely are they being followed at the various levels of the healthcare system, primary, secondary and tertiary levels? To what extent is the active management of the third stage of labour implemented? And so administration of oxytocin in the third stage of labour is known to prevent the incidences of postpartum hemorrhage. Is an inhaled drug delivery product culturally acceptable? What are the implications to an inhaled product? Is there a preference for nasal or oral? What about the device intuitiveness? And is it safe? Is it likely to be used as per the directions? And we recognise going into this that actually the biggest challenge that we face is not the pharmaceutical science, but it's the education, the implementation and the translation. So we took with us a number of devices. We were speaking to vendors who manufacture devices that are all low cost, what we see as simple to use and might be suitable for emerging market application. And we took those with us when we went out and talked to some of the stakeholders. And so we went to a small village in northern India, Shivgar, a population of about 1,000 people, and we sat down with the aid of some interpreters and translators to ask them about their experiences in pregnancy, and did they give birth at home, and what stopped them from, there was a clinic not far away, why didn't they choose to go to the clinic, who was with them when they gave birth, would they feel comfortable self-medicating with something that normally is only available from the doctors. And so we spent the afternoon talking with mothers and grandmothers and mother-in-laws and some of the children as well. And the feedback that we got, which I'll summarise shortly, is just going to be absolutely critical to the path that we take moving forward. But we won't only go through this process in India. We've got plans for getting similar information in sub-Saharan Africa within the next few months, and also it's a huge problem for some of our nearest neighbours in Indonesia and Papua New Guinea that have some of the highest maternal mortality rates in the world. So when we were visiting the different healthcare facilities within the system, we see that the first point of call is someone who's referred to as an ASHA, an accredited social health activist, and her role is to incentivise, to try and encourage the women to go to a facility, because ideally that's the best place, that would be the safest place to give birth. But culturally and traditionally, that's not where these women give birth. They would rather give birth at home because that's what their mother did and her mother before that. And so quite often we found that the ASHAs, in fact, would be present at the birth. They would supervise the birth, and then they would communicate that birth to the nearest primary care facility and fill in the paperwork, and she'd still get her incentive, and so would the mother. But still, it was some contact with someone who'd had some level of training. Then we talked to auxiliary nurse midwives, and did they have oxytocin present, or did they have access to cold chain storage? And sometimes yes, but most of the time no. Primary care facilities, the next point of care, maybe there was oxytocin, maybe it was refrigerated, but not in all places. And then in fact I talked to the head physician in one primary facility and sort of asked, what's your usage of oxytocin? He said, I don't do that. Don't do uterine massage, I tell people not to bother. But the evidence is out there to say that it can save lives. But that was her preference, and that was what was happening. Into the community healthcare centre, again, variable levels of care. And the longer we were in India, the more we realised the size of the challenge ahead of us. But the longer we were in India, the more our determination and passion to be able to see this happen grew. When we got to the tertiary care facility, there was another interesting dichotomy, in that the head of the facility said 50% of the births are booked into the hospital, and the rate of PPH, postpartum hemorrhage, in that group is very low, almost nil. The other 50% of the childbirths that occur in the hospital are the emergency births that occur, somebody arrives after referral from elsewhere where they're already bleeding. And by the time they get to the tertiary care facility and they're triaged, they've often lost so much blood that it's too late. And so the maternal mortality rates in the tertiary care facilities are higher than at the other facilities that make their metrics look not so good. Why are your patients dying? Well, because the time they get them, they're extremely unwell. So these arrows represent the point in time where women are dying. Not at their first contact or their second contact with the healthcare facility, but on transit to their second point of referral or their third point of referral. And so, again, we're looking at finding a solution where if we can give access to oxytocin earlier on, we might be able to at least initiate some sort of healthcare support for them before they've lost so much blood that it's then too late to save their lives. We were investigating cold chain storage, so we went to the local drug peddler to say, can we buy some oxytocin? You need a prescription. So I haven't got one. Oh, okay, we'll give it to you anyway, thank you. I was very concerned when I arrived back in Australia and they were filming border security. Anyway, we did buy some ampules and we're analysing the content of oxytocin in those ampules today because he took them off the shelf. There was no cold chain storage. It was 35 degrees and 90% humidity. And so we suspect that the content of that oxytocin is much lower. Again, this was a photo from a hospital, no cold chain storage. They see over 600 women deliver every month and there's no oxytocin available in the hospital. Oxytocin's even harder to access, we found out in India, because the government has restricted access and availability to oxytocin because it's been used in the dairy industry to increase milk production. And I know they're not dairy cows, but they were the only photo I had. But strangely enough, the things you learn when you go out and talk to people, oxytocin's also being used to increase the size of vegetables. And so they're injecting pumpkins. And so it's harder for women who need oxytocin during childbirth to get it because it's been restricted to stop its inappropriate use in increasing the size of vegetables. So to summarise quickly, what were our main findings? When we spoke to the women in the community and the traditional healers, referred to as quacks in the local area, here's a medication in an inhaler that'll stop bleeding. But you can't stop bleeding. You have to remove 9 months worth of pollution that have built up in these women. So if we go out with a product to stop bleeding, nobody's going to use it because that's contradictory to their belief. And we don't want to come in with a product and sort of dish out on their beliefs and sort of say, well, that's not true, of course there's not pollution. We want to come in and be accepting and understanding and find a way that we can introduce something that runs in parallel and supports those traditional beliefs. We said, have you ever experienced or come across women who die from bleeding after pregnancy? No, nobody dies from bleeding after pregnancy. They do die from weakness though. So there isn't a link that the women who are weak have lost blood and they're anemic on top of that. The idea of inhalation as a product was very well received, which was a relief to us, but we weren't sure. We had no idea whether that would be well received or not. But the feedback at every point of our discussions was that orally inhaled products was acceptable. It was associated, they used steam inhalations, menthol inhalations for colds, much like we might, and it was seen as a cleansing process, whereas intranasal was viewed more as something for mind-altering substances, and if you breathe it into your nose, it's very close to your brain, and they wouldn't like that. And so we've already answered one of those questions to save us going down the path of developing an intranasal product, at least in India, in this area, intranasal isn't a viable option. We also saw in the healthcare setting at the tertiary level that the senior clinicians were sort of like, you can't really give a product for people for self-administration because those people can't really help themselves. They didn't give them any credit for their intelligence or capability as individuals who just want to survive. And yet when we talked to those individuals in the villages, we knew they were incredibly intelligent and capable people who, if given the opportunity, given the training and given access to the resource, will be able to make decisions to improve their health outcome. So anyway, I'll wrap that up at this point in time, and just to acknowledge that the funding we have received to this point in time has been from the Bill and Melinda Gates Foundation, and also through a partnership of funding agencies here through a program called Saving Lives at Birth. Thank you very much.